A blood test to monitor multiple sclerosis. Let's take a look at Octave's Multiple Sclerosis Disease Activity MSDA test. This looks at 18 biomarkers to measure disease activity and potentially guide treatment for people with MS. It looks at these 18 proteins, which can be broken into different categories that focus on inflammation, immunomodulation, myelin, and integrity of the axons. Please see citations for this presentation in the notes below, and be aware that a lot of the data I'm going to show are unpublished and were only presented at scientific meetings and have not been peer-reviewed. Also, the authors of a lot of this data are affiliated with a company that makes and promotes and sells this test, so it could potentially be biased. Also, I should reveal my own bias. Different doctors have different styles of practice, and I'm definitely the sort of doctor who believes in performing less diagnostic tests. I think that American doctors often perform too many tests, which amounts to theater and is not beneficial to the patient and can even be harmful if people put too much confidence in the test, and I would want to see significant evidence that the test has value. Many of these proteins are well known. For instance, neurofilament light chain is a component of the axon or nerve fiber and is elevated during multiple sclerosis attacks and correlates with prognosis. The same with GFAP, and also MOG, myelin oligodendrocyte glycoprotein, is a component of myelin, and many of these proteins are related to the immune system. For instance, interleukin 12 is one of the cytokines associated with MS inflammation. Here's a diagram of a neuron, an axon or nerve fiber, and the myelin in blue, and you can see if we zoom in on the axon, you can see neurofilament, one of the components of which is neurofilament light chain, and when there's an injury to the nerve fiber, it can spill out into the cerebrospinal fluid and the blood, and increased levels are associated with attacks and worse prognosis. For instance, this study looked at the progression of multiple sclerosis as based on the EDSS scale, or Expanded Disability Status Scale, over an 8-year period. And if you looked at the level of neurofilament light chain in the blood at year 3, just a single point in time, there was a weak correlation between overall progression of disability. The R, or correlation value, was only 0.27, but this is just 1 point of time. So the idea of Octave's test, if you take many biomarkers, each of which has a relatively low correlation with overall disability progression, overall you may be able to create a stronger prediction of disease activity and potentially guide treatment. Here you see the neuron and the axon and the myelin and the astrocytes, or supportive cells of the nervous system, in green, and damaged astrocytes have abundant gliofibrillary acidic protein, which can then leak out into the blood and be elevated, also a marker of central nervous system injury in MS along with other conditions. One study, for instance, found that for each doubling or twofold increase of the GFAP level in the blood, it's linked to an increased rate of gray matter or cortical volume loss or shrinkage or atrophy by 0.25% per year. And this was highly statistically significant with a p-value less than 0.0001, and likely clinically significant, as this is approximately the rate of atrophy in normal aging for someone without neurological disease. So you're essentially losing an increased year of atrophy of brain volume just based on the elevated level of this biomarker. Here we're zoomed on the axon and the myelin or fatty sheath, the target of inflammation in multiple sclerosis, and one component of that sheath is MOG, or myelin oligodendrocyte glycoprotein. When it's injured, levels can be increased in the blood. And here are some of Octave's biomarkers related to inflammation. CD6, this is a membrane protein on T lymphocytes, and this binds to ALCAM. I have a whole separate video on this exact protein, activated leukocyte cell adhesion molecule, which is involved in the trafficking of B lymphocytes, the white blood cells that make antibodies, the targets of drugs like rituximab, Ocrevus, Kesimpta, Briumvi, which then traffic into the central nervous system. If you have autoreactive B lymphocytes in the periphery, they're harmless, but if they enter the central nervous system and cause injury, that's part of the pathogenesis of MS. CXCL9, this is a chemokine or cell signaling protein. Interestingly, it's induced by gamma interferon. Gamma interferon is another protein which was once studied as a treatment of multiple sclerosis, but it actually ended up making MS worse. So it makes sense that elevation of this chemokine could be bad for people with MS. It's involved in white blood cell activation. Interleukin 12B, this is a subunit of interleukin 12, a cell signaling protein, a cytokine, which causes white blood cells, CD4 positive or helper T cells, to differentiate towards the T helper cell type 1 pathway, which is known to be associated with MS inflammation. So how did they create this test anyway? How did they choose these 18 biomarkers? Well, they had a lot of data from a lot of people with MS, blood samples, their MRI scans, their clinical activity. They considered 14,000 potential candidate proteins, and the model was trained on MRI findings like gadolinium positive or enhancing lesions indicating a new lesion, or a lesion that was not present on the prior MRI or enlarging lesion, and they looked at clinical activities such as relapses and progression of disability, and they chose the biomarkers most associated with these changes. They originally had 21 candidates, but some of them had some technical problems like diurnal variation. They would have different values if you tested them in the morning or the evening, so they pared it down to 18. So how does Octave's test perform? Here's the data for gadolinium enhancing lesions. In other words, does the person with MS not have active lesions, this column, or do they have at least one active or enhancing lesion, a lesion that takes up the contrast dye? There are 188 participants. They divided them into a low score on the Octave test or a moderate or high score. I'll explain those cutoffs in a moment. And you can see for people who had lower scores, 69 had no enhancing lesions, 20 had at least one. But for people with moderate or high scores, 43 had no enhancing lesions, and 56, the majority, had at least one. So there's a clear difference. If you look at the positive predictive value, if you're in the moderate to high score category, you have a 56.6% probability of having at least one active lesion, whereas the negative predictive value was 0.775, meaning if you have a low score, you have a 77.5% chance of not having any active lesions. Said in a different way, the probability of having at least one active lesion is 4.49 times higher if you have a moderate or high score versus a low score. So there's definitely association. When looking at multiple active lesions, the data were even stronger. So now the columns are divided into 0 or 1 active lesion versus 2 or more gadolinium enhancing lesions. And for people with a low or moderate score, 155 had 0 or 1 active lesions versus only 8 with multiple lesions. Whereas for people with higher scores, it was a 50-50 split, 12 with 0 or 1 lesion and 13 with multiple enhancing lesions. Said in a different way, if you have a high score, you have a 20.99-fold higher probability of having multiple active lesions on your MRI at that point in time. And by the way, when you get the results of this test, what you're going to see is the overall score, but you're also going to see the levels of individual proteins if you wanted to focus on something specific like serum neurofilament light chain or GFAP or MOG. You're also going to see the percentile compared to other people with MS and longitudinal trends over time. So this is sort of a fake score report. This is not from a real individual with MS, and you can see the trend of the score over time. It's going down, and it's currently low with a score of 2.5, and you can see what it was in the past. And you can see the scores in different categories: neuroinflammation, myelin biology score, and if you wanted to, you could look at the individual proteins. The scoring is from 1 to 10. You can't score 0 by increments of 0.5. A low score is considered 1 to 4. A moderate score is 4.5 to 7, and 7.5 to 10 is considered high. And here's a distribution of what scores look like in a sample of 64 individuals with MS. So no one scored 1, 9.5, or 10, but basically every other score score is possible, with the typical score being around 4 or 5. Here's a study on 202 people with MS. This is actually unpublished from a poster presented at a multiple sclerosis conference in 2023, median follow-up at 6 years. And they looked at the different Octave biomarkers and looked at correlations with different clinical outcomes, and these are the ones that were statistically significant. So time 25-foot walk, how fast someone with MS can walk in 25 feet, CXCL9 was correlated with this outcome. For the 9-hole peg test, a measure of hand function where you have to put pegs into little holes very quickly, neurofilament light chain, GFAP, and CDCP1 were associated with this outcome. For the symbol digit modalities test, this is a measure of cognitive function, CCL20 and CDCP1 were associated with it. For the PACET, another measure of cognitive function, it was CCL20 and GFAP. For EDSS, an overall measure of disability used in MS research, neurofilament light chain, and for processing speed, interleukin 12B subunit, SERPINA9, and CDCP1 were statistically significant. But I actually lied. When you're looking at multiple calculations, multiple analyses simultaneously, you have to do a statistical correction. If you think about it, if you have 18 biomarkers with a p-value of 0.05, just by random chance, around one of those should have a statistically significant result, though it may be in the wrong direction. So you actually have to correct for that, and the only one that's actually statistically significant is neurofilament light chain's association with the 9-hole peg test. This is another way to look at it in graphical form. You can see only the one with the star, neurofilament light chain associated with a 9-hole peg test, was really statistically significant. In this chart, the red circles are a positive correlation and the blue circles are a negative correlation. Now it looks like GFAP is working in opposite directions, but actually a higher score on the 9-hole peg test is worse. You want to be able to perform the test quickly, whereas with the PACET, a higher score is actually better, hence the negative correlation. So there's nothing funny going on here, but really only one evaluation was statistically significant, and neurofilament light chain is probably the most established of all of these biomarkers. Now, one criticism of biomarker testing in MS is that it really is only a reflection of what's going on right now and doesn't necessarily predict the future. So if you have a relapse or active lesions on MRI, it would make sense that there's injury to tissue and those proteins could leak out into the blood like neurofilament light chain and GFAP, but what's going to happen a year from now or 5 years from now, that would be useful information. So this study tried to use machine learning to predict who will get optic neuritis in the future based on these biomarkers. They had 109 participants who underwent the Octave panel, and they created a validation F1 score, which was 0.67. And according to my research, this is kind of a mediocre performance, would not typically be used to actually make decisions in the real world for most things, though there is a correlation. And interestingly, what predicted optic neuritis in the future the best were OPN, CXCL13, and CXCL9. So a couple of the immune markers, not the more established GFAP and neurofilament light chain. This is an interesting cross-sectional study that looks at patient-determined disease steps. So this is where the person with MS fills out a survey to estimate their EDSS, to estimate their expanded disability status scale, and this has been a validated outcome, although it may be a little bit different from what a physician may determine. Now, they actually used 19 proteins, so it's the Octave panel plus this one other protein, VCAN, which was later eliminated from Octave's panel for technical reasons. If you look at the central column, the prediction of disability was 71% sensitive and 83% specific. The correlation coefficient squared was 0.28, so only 28% of disability could be explained by these biomarkers. And again, this is just a cross-sectional study, just one point in time, though in the right column, they found that if you combined clinical features with the biomarkers, it was a little bit more accurate. This next one's really interesting. This is data from the Ultimate 1 and 2 trials. These were randomized trials in relapsing MS which compared the drug Briumvi, ublituximab in white, versus Aubagio, teriflunomide in blue. Briumvi is a B-cell depleting infusion. It kills B lymphocytes similar to the drug Ocrevus rituximab or Kesimpta, and it's considered to be highly effective in MS, whereas Aubagio is a once-a-day pill considered to be less effective, and in these trials, Briumvi was in fact more effective than Aubagio in other outcomes like in preventing new MRI lesions and relapses. Here's the data on the overall score for the Octave panel, and you can see at the beginning of the study, week 0, they were about the same, but very quickly the score in people getting Briumvi, the white, plummets, and it's very low with a huge and statistically significant difference by even week 24, but more so by week 48 and 96. In fact, when you look at the data, it's quite striking. So on the top, I have the data for Briumvi, and at baseline, only 15% had low scores, 9 out of 61 participants, but by week 96, 100%, all of them had low scores. So it would seem that B-cell depleters are highly effective at making Octave's panel have a favorable result. And it actually took a long time to go down. You can see at week 24 and at week 48, there are still 15 and 10% respectively with moderate scores. So how long does it take for Octave's panel to normalize in people who had active disease, who are treated with highly effective disease-modifying therapies? It may take up to 2 years. If you look at the Aubagio data on the bottom, it's much less impressive. Even by the end of the study, 25% have high scores, 45% have moderate scores, and only 30% have low scores. Now keep in mind, these are very low numbers. There's not data on this biomarker in all participants in the trial. I'm not sure if there were any kind of systemic biases. The other problem with this is, what exactly is the point of doing the Octave test if you're taking a drug like this, if essentially 100% of people are going to have a low score? Another issue is it shows that this test really does mostly measure acute injury to the nervous system, which could be reflected in things like gadolinium-positive lesions, and of course Briumvi is extremely good at suppressing active lesions, nearly 100% effective in the long run. However, it obviously does not prevent 100% of disability progression. For instance, in the Oratorio trial, the randomized trial of Ocrevus versus placebo in primary progressive MS, it was only about 25% effective of actual reduction in disability progression, even though it was highly effective at suppressing active lesions. So the billing of the Octave test as measuring something like smoldering multiple sclerosis, I'm not sure if that's really true, because obviously some of these people must have some smoldering multiple sclerosis. It's not like everyone getting Briumvi is stable, but according to this test, they are. Another interesting thing is that although Briumvi was very effective at suppressing levels of things like GFAP and neurofilament light chain, there were other things where it didn't work at all. So here you can see the white and blue bars for these biomarkers are roughly the same. It didn't really matter if you got Aubagio or Briumvi. It'd be interesting to know what these biomarkers are doing and maybe if a different type of treatment could target them more effectively. The next question is, are people using this test to make decisions? Are doctors and people with MS making decisions about disease-modifying therapy based on the results? Well, this is a longitudinal chart review of 352 people with MS undergoing the Octave MSDA test. And it looked at the score on the left-hand column, higher being a worse score, and the decision that was made. Now, on the very right is people who initiated disease-modifying therapy, and it makes sense that a lot of people are diagnosed after a relapse, so they're often going to have a high score, and most doctors are going to recommend to start some form of treatment. However, if you look at the other 4 columns, continuing the medication, discontinuing the medication, changing to a different medication, they're all roughly the same. That's more clear in this graph. You can see Even people who have high or moderate scores, it seems like the doctor is recommending essentially to stay on the same medication. So I don't know how much doctors are trusting the score. Maybe people would need to be more comfortable with it over time. Another potential problem is this test useful for people who are already on highly effective disease-modifying therapies? I mean, what else can you do except take a strong medication? Can you change it to a different strong medication? Well, this study looked at serum neurofilament light chain. This is not the Octave test, just one of the biomarkers, and the probability of having an EDSS, or Expanded Disability Status Scale, of at least 3 versus less than 3. And there was definitely a correlation. If you had lower levels, the dark blue line, less than 10 picograms per milliliter, you were much less likely to reach EDSS 3 versus the yellow line. However, if this is people who were not treated with highly effective disease-modifying therapies, if you looked at people who were treated with disease-modifying therapies, they overall did better. Less of them reached EDSS 3, but there are now no differences. The biomarker doesn't tell you anything. It doesn't correlate with outcomes at all. The reality is these proteins are messier than you might realize. For instance, here's some data looking at people with MS who had a shorter MS duration, a longer MS duration, people with rheumatoid arthritis, and a healthy control population. And you can see a lot of healthy controls could have these proteins as well. For instance, if you look at CN2N2, 1120 was the average for the short MS duration, 1643 for the long MS duration, and right in between the two, the healthy controls had levels of 1256. And so what exactly is going on here? This looks like a lot of noise. I think they presented it in this really messy, hard to read chart because it's just so embarrassing to the test. Now, that all being said, and I didn't mean to turn this into too much of a hit piece, I think many doctors and many people with MS could find this to be useful, even if it isn't that evidence-based. For instance, it's pretty easy to make your score low. Just take a B-cell depleter, I suppose. But a lot of people may not want to. They may be afraid of the side effects, but if they saw that they had a high score, their doctor could say, hey, listen, there's a lot of injury happening to your nervous system. Even if you feel well, I would recommend a stronger medication, and that may actually convince someone to make a change. Also, MRI scans may not always be available. This blood test is simpler, easier to do than an MRI scan. Even if an MRI is ultimately more accurate, this is simpler. Some people have severe claustrophobia or have a pacemaker and can't readily get an MRI scan, so it could sort of serve as a replacement for an MRI in certain cases. Now, another criticism I would make is that although it kind of tells you what's going on right now, so if you have central nervous system injury and you're taking a low efficacy disease-modifying therapy or not taking disease-modifying therapy, that is very actionable. If you're already taking a highly effective disease-modifying therapy, I think it's less clear that it is warranted to make a change. Also, it's pretty clear that this score can fluctuate a lot. There's some other publications where they show real-life cases where people could have a low score and a high score. If your score is low at a given point of time, that isn't exactly reassuring because the nature of relapsing MS is it's relapsing. People go through remissions. They can have 2 5-year remissions and later have a bad attack and multiple GAD-positive lesions. So unless a low score would tell you you're going to be in remission long term, I don't think it's really that reassuring. And also, it takes time for the score to go down in some cases, as I showed you with that Briumvi data. So even if it's a little bit high after starting a stronger treatment, that isn't necessarily bad news. I'd be interested to know your thoughts. Do you think this test would be useful? Would you actually make a different decision based on the result of the test? And if you've had the test and you know the results, and if you did act on those results or not act on those results, please share in the comments and let me know if you have any ideas for other videos.